Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Welcome back to the Equine Vet Connect podcast here with Dr. Hoffman this morning. Look at there. I'm getting it right.
You're getting it.
You've only been married for almost a year now.
No, like 6 months.
6 months, close enough.
You're doing good.
I'm doing pretty good then.
You're making progress.
Yeah. So we got Dr. Caitlin Hoffman back with us this morning.
Yep, it's me.
And, it's a beautiful Friday morning. Spring. I love spring.
There's pollen.
Everywhere.
Yeah.
For those of you who don't live in the Southeast, we most people experience spring. It's a lovely time of year where we can open your windows and let the breeze blow through and out. We're inundated with yellowness that you can't even imagine. Yeah. So
I can't even walk on my front porch.
No.
It's like you could slide across it. There's so much pollen.
We got horses that try to slip walking out of the clinic here on a non-slip surface. It's that much pollen. So, yeah. So, in case y'all are wondering, we film these pretty close to the time they air. So,
yeah.
But, so we're going to talk about another tragedy today. We're going to talk about wounds on equine legs.
Yeah.
Because, one, horses like to get hurt.
Oh, yeah. It's their jobs.
Yes.
Job security for us. I mean.
And two, like, if they're going to get hurt, it's going to involve an eyelid or a leg, I've decided.
Yeah. That's pretty accurate.
That's what they're going to injure.
Yeah.
So one of the things like what we want to talk about today is, a lot of times we get these wounds on the leg and people are like, I don't know if I should call, not call.
Please call.
Please call. Because we're going to talk about, like, there's a lot of stuff down there that if you hit, this can go bad. Early intervention. I think that is the key to equine medicine, probably medicine in general.
Yeah. Early
intervention solves a lot of problems.
It does. Yeah. And we're talking early, like within the next, like the first 6 to 8 hours early, definitely within the first 24 hours, we need to see them. But that golden window is like 6 to 8 hours. If you can see it in that time frame, there's some things we can do. Yeah.
Going over 24 hours and risk factors really go up.
Yeah. For sure. But yeah, wounds, the first thing, if the receptionists get a hold of us and they're like, hey, we've got a horse with a wound, my first question is, where is it?
Yes.
That's my first question.
Mine's just, where's the horse? Y'all's is probably, where's the wound on the horse? I'm just like, well, where's the horse at?
Yeah.
I'm just going to go.
Yeah. Yeah. Where's the wound? And then, can I have a picture of it? So that I can kind of formulate in my brain, where is it? What structures are there? What's my game plan going to be? How much of an estimate do I need to possibly give this person? So we can get a lot from a picture, but yeah, please call.
Yeah. So we're going to talk about that because what you run into is that when you're looking at wounds, there's more than just penetrating through the skin. There is a lot of, I think we're going to start with like what we call synovial structures.
Yeah.
These are joints, tendon sheaths, different places where, like I said, different joints and different tendon sheaths, anywhere that's making like synovial fluids. Because what you need to understand is these synovial structures are kind of, I'm trying to think of how to explain it. It's sort of like the body gives them like special privileges. Like you get to hang out over here. We're not going to put a lot of immune cells in here.
Nope.
You're not going to be good at fighting infection.
They're protected from the rest of the body is what they say.
Right. So even like when you get sick, it's rare. I mean, it does happen, but it's rare that if you get like bacteria floating around the bloodstream, it typically does not get into these structures. They're protected.
Yeah.
Downside is they're protected. So when infection does get in there, it wreaks havoc.
Yeah, because there's not the immune cells in the blood flow getting to those locations to help fight those infections. So the bacteria can just throw a party.
Right. And the problem you run into is by the time the body does decide to mount an immune response, it is way too late.
And the stuff that's in those synovial structures, other than just the synovial fluid, is very important structures like, giant flexor tendons or joints where you have cartilage, and that's what is your gliding surface so that your joints can work and your body can move comfortably. If those structures get damaged because that synovial fluid is damaged or infected, we're SOL. I mean,
oh yeah, it's bad. I mean, bacteria will destroy cartilage. The byproducts of getting rid of it, so the byproducts of these different immune cells, the enzymes they release out of white cells, not real healthy on joint cartilage.
No.
And then I always say, like, I used to think having an infection in the joint was the worst thing possible.
It's not.
No, those tendon sheaths, way worse.
Yeah.
Way worse, because if those tendons do get infected and they get necrotic, it's all but impossible.
Yeah. Yeah, so the early intervention is key. If we can get in there in the first 24 hours and do what we need to do, we stand a much better chance. It's still not a great chance, but we stand a chance.
Yeah, joints I feel like we can do fair. Like, joints don't really worry me if I get them in the first 24 hours.
Yeah.
Tendon sheaths are the ones that really bother me. So let's talk a little bit about the anatomy. Let's start with below the fetlock. So let's start with the pastern area. Let's talk about all the different synovial structures that are just inside the pastern area. We're talking an area of what, 6-8 inches?
Yeah, and on your own anatomy, like, this is from basically your big knuckle bone on your middle finger down to your fingertip is what we're talking about. So if you think about, there's not a lot of meat there.
No. Yes, if you're watching on YouTube, Casey's going to throw a picture up there, and you can kind of see some of these structures as we go through them. So
yeah. But yeah, in that area, you've got, in your hoof itself, you've got your coffin bone and your navicular bone, and around that navicular bone is your navicular bursa, which is a synovial structure.
And this is one where when we talk about that navicular bone and navicular bursa, this is where when you step on a nail, this is what we worry about. Don't pull the nail out. We'll get to that later.
Yeah, please don't. The other thing, your deep digital flexor tendon runs down the back of that whole navicular bursa and your coffin bone and attaches to the bottom of the coffin bone. So we also worry about that if you step on a nail. The other synovial structure you've got in there is your actual coffin joint.
Yep.
So just in that hoof capsule, there's 3 big structures in there that we're like, oh crap.
And notice we didn't mention a lot about the bone. The bone we're pretty good at taking care of.
Yeah, we're still worried about it.
Yeah.
If it gets poked by something, we're still going to be like, oh yeah, we need to take care of that. But we can do that. Yeah, that's not
a whole lot of worry.
No, but the synovial structures and the soft tissue structures, we need to know. Yeah.
Yep.
And then going up the next level to kind of your pastern, obviously you've got your pastern joint, and which is a synovial structure, and then you've got your deep digital and your superficial digital flexor tendons that run down the back of that pastern, and this is where you start to get into your digital flexor tendon and sheath, which is huge.
Yeah, it starts just size-wise. It's going to start all the way down by the navicular bone. It goes all the way up the back of the pastern, through the palmar canal or plantar canal, the fetlock joint.
Yep.
And then actually goes a third of the way up the cannon bone in the back of the leg.
Yeah.
It's a big structure.
It's a very big structure. And so any wounds that are on kind of the back of the leg from like basically mid cannon down to the hoof capsule, we're like, we need to see this ASAP. Yeah.
This is on our list. We're concerned. We need to take a look.
And you can't tell how deep a wound is unless you like actually explore it and probe it. You can't.
Right.
So a picture is not going to be enough. An owner looking at it and being like, oh yeah, I don't think it's deep. I've had people say that to me, and then I get in there with a probe and I sink all the way down to the bone.
Yep.
Like you've got to please call and let us look at it.
Because I can't tell you how many I've gone out to, and you look at them like, no, it's like nothing. Then you start to explore. The probe falls off. You do a contrast study, which we'll talk about.
Yeah.
And here we are.
Yeah. Yeah, it's a big deal.
Most of the pastern joint and coffin joints, most of those are going to be more on the front of the leg. They're on the back of the leg, but you're going to hit the tendon sheath before you get to them.
Correct. Yes.
So
yeah.
Wounds on the front of the leg, even on the side of the leg, we're concerned about those.
Yeah, for sure. Moving up, you've got your fetlock joint, which is a big synovial structure.
Massive. So it goes, again, it's going to go maybe a quarter of the way up the cannonbone. It's going to extend up quite a bit on the back of the leg. A lot further than most people realize.
Yeah. And again, we can get into this guy. I look at it from how do we inject this joint capsule,
right?
The synovial capsule. We've got basically 3 different approaches.
5.
5? Oh, it is 5. Yeah, we use 3 the most, but yeah, there is 5. So if we can get into it on purpose 5 different ways, that's a lot of wounds.
Yeah, and anything in that fetlock region, because that joint is so big, anything in that fetlock area can contact it.
Yeah.
And like, especially a lot of people don't think on the front of that joint, that front of the front of that fetlock joint, the dorsal, we'll call the dorsal aspect of the front of it, it extends up quite a bit above where you think the joint is.
Oh, yeah.
It's a much bigger joint than it's given credit for.
Yeah, it is. So any wounds in the fetlock area on any part of the leg going around it, we need to know about it. But then, yeah, as you said, on the back of that, we've got, your flexor tendons coming down in the palmar or the plantar canal, and you've got your tendon sheath is back there. You've got your suspensory, and your suspensory branches are back there. There's a lot of structures going on in there. You've got your sesamoid bones, all your sesamoidean ligaments. There's a lot going on right there.
Right. And I've had wounds that got into the deep and superficial that were outside of the tendon sheath. Those typically do pretty well.
Yeah.
But when they're in that immunoprivileged site of a synovial structure, they don't do near as well.
Because they don't have any help.
None.
Yeah.
None.
So, we just need to know. And then moving up the back of that cannon bone, obviously you've got all your flexors and you've got your tendon sheath that extends up so far. So that area, we can do a lot with when it's outside the tendon sheath. You've still got, your splint bones that we're worried about. Those can get whacked and fractured, and we need to know about that. But then moving up to kind of your carpus or your knee, that's another big synovial structure.
Oh, yeah. I mean, there's 3 different joints up there. And 2 of them do communicate, but and then you get the palmar-carpal canal on the back of it. Yeah. And also you get the extensor carpi radialis. It has its own tendon sheath up there. I mean, there's synovial structures everywhere. Yeah. Basically what you want to think about, if it can move, there's a synovial structure there. Yeah. If anything's got to move, slide, anything, because that's one of the purposes of these tendon sheaths is to reduce friction. And so anytime something's moving, sliding, or bending, there's a synovial structure there.
Yeah. Its purpose is to help things glide over bony surfaces is the point. So basically what we're trying to say is there's a lot of stuff going on down there. There's a lot of important stuff down there. And if anything pokes it, tears it, gets stuck in it, we need to know about it.
Yeah, that's... And I think let's bring that up. Let's talk about if something poked it. If you had to ask me what I'm more worried about, is it the deep cut that gets into that structure, or if I'm dealing with a puncture? It's puncture all day long.
All day.
Because I may not know. Because a lot of times you'll get these puncture wounds. Wood's the absolute worst. Yeah. But you'll get these puncture wounds and you have no idea that the structure's even been... It has even been penetrated.
Yeah, and this is where the timing comes in, because those synovial structures, they're very good at sealing themselves back up.
That's what they're supposed to do.
So what happens is, what we get the most concerned about is when we have a puncture wound and it punctures, and we do what we call a contrast study, which is where we get our x-ray machine out, we put some contrast material into the wound, and the contrast material shows up bright white on your x-ray, and we basically put that into the wound and we take an x-ray and we see where it goes to try and figure out what structures are affected, how deep the wound goes, did it hit anything important. The problem is if it did puncture that tendon sheath or that synovial structure and it's been, several hours, that could seal back up and we don't see the communication with that synovial structure on our contrast study. I can't be 100% sure that it happened or didn't happen. So if I don't know, then we're behind the 8 ball.
No, and that's where it gets very difficult because some of these smaller ones, it is like a splinter. Just a small splinter happened to get in there, or a small tiny nail. And that synovial structure just sealed back up.
Yep.
And then it's like, what do you do? And besides just contrast studies, we can also do, we'll actually pressurize some of these joints. So sometimes we'll actually go in, scrub these joints, just like we're doing a joint injection. It's a sterile prep. And we'll fill it with saline. And our whole goal is like, is this thing leaking? So we start pressurizing this joint, hoping that if it was a small puncture wound, it's going to start to leak.
Yeah.
And if we see that, then we're 100% certain this joint's involved.
Yeah.
If we don't see that, we're just partially concerned. Like we're going to be concerned. Anything like it hits a certain area, it is on our radar.
Yeah.
And like I said, the ones that are the scariest are the ones that have the penetrating wounds that do seal up before we can get there. Which is why trying to get there early is better than late, because the longer you wait,
the worse it's going to be.
The more time that area has to seal up.
Yep.
So sooner we can see it and get it figured out, the better.
Yeah, for sure. You know, and this is where the communication comes in, and, you know, just call.
Yeah.
Please.
We are nice people.
We are.
It's one of those things I talk to people like, oh, I'm so terrified to call the vet. I was like, we are really nice people. Vets are, in general, we're nice people.
Yeah.
Our staffs are generally nice people. At least ours is here.
We're here to help. That's the whole point.
And that is 99% of veterinarians. They just want to help.
Yeah.
And we're going to take the call. Like, just call us. We're nice people.
And if you call us early on in the process, we can help you a heck of a lot easier.
Yes.
Than if we're, 24 hours late. So, but yeah, we can, there's different diagnostics we can do while we're there. Probing the wound is a huge thing. Exploring the wound, seeing where it goes, how deep it goes, what direction it goes. Sometimes these things, they look really small and, not scary on the outside. And then you probe them and, like you said, they fall off and they go down to the bone, or they go in a completely different direction than you thought, or they've got a big pocket under the skin that, is now a bunch of dead space. And that completely changes how we treat these things. But then also, getting in there and getting, a culture swab so we can see, if there's bacteria in there, what bacteria are growing, so we know how to treat it. There's a lot that we can do in that first visit to say, make a game plan. So,
and one of the things is if we get out there and it's been a while, one of the other things we'll do a lot of times is get a sample from the joint. Do what's called an arthrocentesis or a joint tap. And this is, again, where we're going to go in sterilely. But our whole goal is to get a sample of that joint fluid. And then we can put it back through a machine. We can get what's called total nucleated cell count. If that nucleated cell count's high, that increases the likelihood that's an infected joint.
Yeah. Because remember, they're not supposed to have a lot of cells in there.
No,
in the
less
first
than
place.
500 per deciliter. I don't know. It's on the machine.
Yeah.
It's less than 500 of whatever that is.
Yeah.
So, yeah.
So if there are a lot of cells in there, that definitely increases our suspicion that this is definitely a septic joint or a septic synovial structure.
Yeah, because we'll see those. And one thing to remember, a lot of people say, well, they didn't have a fever. I'll be real honest. I think I might have had one septic joint in my career other than in foals.
Yeah.
But if it's adult horses, the majority of them do not have an elevated temperature. And they actually don't have an elevated white count.
Because, again, it's separate from the immune system. It's separate from the rest of the body. So that it doesn't set off the alarm bells.
So trying to say, like, oh, I'll just keep an eye on temperature and that'll tell me if this got infected. Nope. Doesn't work. Because, like I said, I've had, out of the hundreds I've dealt with, I think other than foals, I might have had one with a temperature. One that actually had a fever. Blood work's always really unremarkable. Yeah. And you tap the joint and you got a 70,000 total nucleated cell count.
Bingo.
Like, it's septic.
Yeah.
I'm old school. I love a cytology.
Yeah.
I still love a cytology.
Yeah.
That's always my favorite is, I'm waiting on that to come back. I'm looking under a microscope and it's like, well, I have bacteria.
Yeah.
It's infected.
Yeah. Easy.
Yeah.
Takes 5 minutes.
Yeah, it's quick, it's simple, it's easy.
Yeah.
Gives us a lot of information. And so those are some of the things that your veterinarian is going to do when they show up. And you may think, like, I don't know why they're going through all these steps. Like, can't you just sew this thing up and move on with life? Why do we need to get an x-ray? Why do we need to do all this contrast stuff? Why we got to put dye in it?
And we didn't talk about really broken bones too.
Oh, yeah.
Like, you can have coffin bone fractures, navicular bone fractures, pastern fractures, your sesamoids can fracture. Like, any of those bones can fracture, and they don't have to look broken when you get there.
Well, knowing too, like when we talk about probing a wound and get, like, a lot of times we'll get an x-ray with that probe in the wound. And if it contacts bone, that's going to send us down a whole nother path.
Yeah.
Bone can do what we call sequester. And that doesn't show up it can take up to 2 weeks for this to show up. And it's where you have a penetrating type injury or a traumatic type injury to the bone. And that bone loses blood supply. And the little piece of it will actually fragment off, like from necrosis. And we won't see that day. But if we go in and probe that wound and we this definitely hit the bone, that's the discussion your veterinarian's going to have with you. They're going to say, hey, look, I need to follow up in 2 weeks because I need to know, did we get a sequestrum? And it can take a full 14 days. Like, I don't x-ray those. I don't recheck those at day 13.
Nope.
I recheck them at day 14.
Yeah. Because
I've checked them at day 12. Life was good. Then I got a draining track on day 16, and there it is. It's a 14-day recheck.
Yeah.
So that's important to know that this is a likelihood. So if a draining tract develops, it's not we need to change antibiotics. It's like we need to re-radiograph this. Do we have a sequestrum?
Right.
Because if we do have a sequestrum, we've got to go take that out.
Yeah.
And it's not a big deal to take out. It's one of the simpler things we do.
Yeah.
But it has to be done.
It does. But yeah, knowing exactly what structures this gets contacted and, what's involved is huge. And, but yeah, radiographs tell us a lot. And then, as far as planning for, antibiotic choices if needed and, if we can suture it, do we need to place a drain? Do we not need to place a drain? Can we place a drain? And then, can we suture it? Is it going to hold? How many layers do we need? Like, it's a whole thing that's going through our minds when we're looking at this wound that, you may have thought was a simple little scrape.
And it's not.
It's not.
It's not.
Yeah.
Because I can tell you a lot of people are like, oh, they just cut himself. And, I've been doctoring it. And you get there like, that's in the tendon sheath. That's in the joint. Now we're going to surgery. Yeah. Because that's really what we're trying to decide. Because if we hit one of these synovial structures, this changes a lot of things. It's going to change. I mean, even antibiotic choice. We have some antibiotics that love to penetrate synovial structures. Yeah. We have others that don't. So that's going to dictate what antibiotic we put them on. Next is, in my opinion, if I have a horse and we do end up in a synovial structure, this is a horse that comes in and goes to surgery. I'm old school. I'm laying them down. I know a lot of people are flushing these joints standing. I don't think you can get as good of a flush standing as you can laying them down. Yeah. We're gonna go in. We're gonna put them on the table, and we're going to. When I say lavage it, we're gonna power wash this joint. Yes. Or this tendon sheath. I mean, we're copious amounts. The old saying, the solution to pollution is dilution. Yep. We're gonna dilute the heck out of it. Yeah. We're going to take a joint that holds like 10, 12 mils of fluid, and we're going to run liters of saline through it. Yeah, literally. And our whole goal is to flush all the bacteria out that we can. Get rid of them. Yeah. Just flush them out, flush them out, flush them out. Because if you flush it, then the body has less to clear. Your antibiotics have less to clear. Your risk of necrosis of the tendons or, the cartilage is lower. So... And this is not the time to say, well, if it gets worse, we'll flush if the antibiotics don't work. No, if the antibiotics don't work and then you flush, you are way behind the 8 ball. Because the other thing people will forget is, yes, the bacteria cause problems, but the cells that get rid of these bacteria, like let's talk about our buddy, the neutrophil. Yeah. The neutrophil is like, if a horse has a problem, a neutrophil is showing up. They're coming. Oh, yeah. And not one or two. They produce copious amounts of neutrophils. Love to make a neutrophil. Yes. Yeah. And neutrophils work through a process called phagocytosis. They're going to actually eat the bacteria. And they got these little lysosome granules in there, these little lysosome pouches. And these things like devour the bacteria. But then they do what we call degranulate.
It's like the atomic bomb goes off.
Yes. They kill the bacteria and they just blow up.
Yeah.
And they dump a whole lot of lysozyme.
Yeah. And they're not selective.
No.
They just kill everything.
Yes. And that stuff is toxic as could be to especially joint cartilage.
Yeah.
So it's actually the neutrophils that are probably doing as much. The response does as much to the cartilage as the infection does. Because, I mean, this lysozyme is terrible for joint cartilage.
Yeah.
And so we got to get all those guys out too.
Yeah.
We got to get rid of our bacteria. We got to get rid of our neutrophils. The monocytes, they're not too bad. Horses just don't make a lot of them.
Yeah.
So we have to get all that junk out of this joint because it's destroying this joint.
Yeah.
And we do it by flushing
it out.
Yeah, we're going to pressure wash it out.
It is crazy though when you actually watch a flush. It's like you put a needle in one end and then you put the port in the other end and you're just like, and it's just fluid coming.
Yep, we do them two ways. One's a needle flush, where we pop needles in and flush them. Sometimes, depending on the joint, we'll actually put an arthroscope in. Gives us a camera. We can actually go look around in the joint. Depending on the joint and depending on the wound, that's a really great way to do it because you can look for any foreign material that's in the joint.
Yeah.
We kind of look at, what kind of wound is it? Where's the wound at? What caused the wound? Those are all things that we look at to say, is this going to be a needle flush or is it going to be an arthroscopy?
Yeah.
If I have wood involved and I have splinters involved, I'm going to typically put a scope in.
Yeah.
Because if there's pieces of wood in there, I kind of want to go get the wood out.
Yeah.
So then you take the wood out.
Yeah. We had one of those recently and I was pulling splinters out of this thing a week after it had initially happened.
Well, and that was after we'd gone in surgically.
Yes.
And looked and tried to find it. But the problem is you can't see wood on an x-ray. Not really going to see it on an ultrasound. And these are tiny little splinters. And even with a scope, if it's not in the synovial structure poking through, you can't see it with a scope. So if it's just in the skin and like just kind of scratching it, you're not going to see that.
Yeah.
And that's the other thing I love about, people are like, well, why do you lay them all down? Well, anesthetized horses don't move. We can get in there and do a really good job exploring things.
Yeah.
Like they're not moving. We can do a really good job of looking around for foreign material. We can do a really good job of looking at this wound.
Yeah.
You can really investigate it. The thing that changed my opinion on that is when I was up in Kentucky, we were sewing up we thought was just a simple laceration. We get it in surgery, we get it on the table, we start getting ready to close this, we start exploring the wound, and we're picking paint. We got pieces of paint, shards of metal. And I'll never forget because it was like the third fold that got cut. And we pulled this, we were pulling this paint chips and we were pulling these little pieces of metal out. And I actually called the farm manager in the OR and said, "You got anything that's red?" He goes, "I got a red gate." Guess where the problem was?
Yeah.
So guess what they did not have anymore by the time that foal woke up? They didn't have a red gate. That gate was gone.
Ugh.
But they found a spot on the gate. They were cutting it. But if you just sewed that wound up, you'd have sewed all that material. And
it never would have healed.
No.
Yeah.
So, again, if there's a synovial structure involved, I'm going to surgery. Yeah.
Yeah. And quickly.
Yes.
Yeah.
Because the sooner we can get to it, the less damage we have. One of the things that I'm always concerned about is not just the immediate effects. What's going to happen 1 week, 2 weeks later? And when synovial structures are involved, it can be 2 or 3 weeks before we know fully. Even after we've done everything right, the question then becomes how much cartilage damage did we get? And more importantly, if we're dealing with a tendon sheath, how much damage did we get to that tendon secondary to this infection?
Because they can look really, really good for that first 5 to 7 days after you flush them. They can look fantastic. And then on day 7 or day 8, they are crippled.
Yep.
And you're like, crap, we've done everything we can. And then you stick the probe on there and you see how much tendon damage you have and how much necrosis you have. And you're like, there's nothing else we can do.
And those are ones like if I even think a tendon sheath is involved, I'm getting them in. Like if there's a 5% chance, I want to get those horses in and flush them out.
Yeah.
Because infection in that tendon sheath leads to necrosis of those tendons. And that is something we can't fix. And like I said, downside is it's about day 7.
Yeah.
That seems to be the magic number. We've dealt with a lot of those. It's like we make it to day 10, life's good.
Yeah.
But somewhere around that 5 to 7 day mark it's really tricky.
Yeah. Yeah, and they're frustrating. They're frustrating because you've done everything you can, and like I said, they look really good, and you're like, okay, all right, we might have made it, and then you get to day 7, and you're like, well, we didn't.
They give you hope.
Yeah.
They give you hope.
They do. Yeah.
So, some of the other treatments that we use on these, if these structures are involved, one of them is what's called a regional limb perfusion.
Oh man,
I love these
regional limb parties.
So, when you give an antibiotic, let's say either an oral antibiotic or an IV antibiotic, you're treating the entire body.
Yep.
And so that antibiotic is going everywhere. When you do a regional limb, you're actually using a tourniquet and you're trapping this antibiotic in a smaller area. And sometimes we can use, we use a much lower dose. So it allows us to use antibiotics that we can't normally give systemically.
Yeah.
Either they're cost prohibitive or the side effects of the medication at a therapeutic dose. Some of these medications we use, especially in adult horses, if we were to use the therapeutic dose, our side effects are really high.
Correct.
So, but if we use a lower dose, we're fine. So some of these we can use as much as use like 10% of the systemic dose, but we do it locally. Yeah,
we concentrate it in that area that we're trying to treat and basically just flood that area with antibiotics. And we can get a really, really high concentration in that region.
Some studies have showed up to 100-fold increase in antibiotic concentration in the area.
Yeah. Yeah. And they're not hard to do.
No.
They're not at all. They tend to come in waves for us. And so we'll have like 3 or 4 horses here at a time that are getting regional limbs. And so one of us is just like, okay, well, I'm throwing the party today. And we go and we just do all of them at once. And it's like, but it does. They're not hard to do.
No.
And they're very, very effective.
Very.
Yeah. And we can use them for all kinds of things. Yeah.
One of the other things we'll do sometimes is if a synovial structure is involved, we'll put an antibiotic directly into that structure. So sometimes we'll do that at the time of surgery.
Yep.
Sometimes we'll do that as we're treating them. I've been playing around with some wound diffusion catheters a little bit more lately.
Yeah.
I'm really thinking, I'm thinking I like them.
Yeah.
But this is a cool little catheter that we can put directly into the structure, directly into the wound. And it's kind of cool because it's this fenestrated drain, for lack of a better word. So it's got all these tiny little holes in there. And then you put an injection port and you just inject it straight into that, into that tube. It goes straight to the wound, straight to the synovial structure. And you're putting the antibiotic where you need it. Yeah, because like if the wound's on the left front, we don't need to treat the right hind.
Yeah.
So let's focus on the left front.
Yeah.
And by using things like regional limbs, direct synovial injections, or even these wound diffusion catheters, you just put the antibiotic where you need it.
Yeah.
Like I said, if I'm treating the left front, the right hind's fine. Don't need to treat it. Let's focus it there.
Yeah. So there's a lot of things we can do. And then, a lot of this comes down to daily wound care and management of the wound.
Yes.
And I've had some very long-term
You were like the wound care
cases,
expert around here.
But yeah, bandaging and wound care and cleanliness is extremely important. And, knowing what to use when and, what stage the wound is at and healing and all of this, like it makes a big difference. So when we want to recheck these things multiple times, it's because we know that the wound is an ever-changing environment and we sometimes need to change the plan to best treat the wound.
Well, and it's also really important when we're dealing with these is like you're bandaging and not just keeping it bandaged, but aseptically changing those bandages.
Yes.
Let's don't add bacteria to this.
Yes. Cleanliness is key.
Yes. Because I've definitely had, especially when we're talking about tendon sheaths, I've had some of these that we can't close.
Yeah.
Like we have to let them heal what we call second intention. And so this synovial structure is still open to the world. So when we change that bandage, this is a very aseptic process.
Yeah.
We're trying not to add bacteria to this.
Yes.
So this isn't something you want to do in the hallway of the barn, not something you want to do in the stall. We're going to bring it into as dust-free environment as we can.
Mm-hmm.
This is coming from our barn over to the hospital into an exam room, and we're changing that bandage very, very aseptically.
And this is just the same as why, like, when we do joint injections or tendon sheath injections out in the field, we get kind of fussy about turn all the fans off. Nobody's sweeping the barn aisles. Nobody's walking past. Nobody's grooming a horse next to me in the middle of shedding season. Like, we get a little bit OCD about it because we're trying to stay clean.
Right.
Yeah.
So there's a lot of factors that go into it other than just we got to change a bandage. Mm-hmm. It's how that bandage changed. Those are all very, very critical.
Yeah.
Like I said, a lot of times we're doing regional limb perfusions with this. We're going to do those at the same time. Mm-hmm. And all the little things add up to success.
Yes.
And some of these structures, no matter what we do, we're going to fail.
Yeah.
And those are the hardest.
Yeah.
And I can tell you, I've decided tendon sheaths, I think if you can get them in the first 24 hours, you have a much better shot.
Still not 100%.
Still not a guarantee.
No.
But I've definitely had some that they were 2 to 3 days. It was a cut on the back of the pastern. Nobody thought anything about it. And we get those in, and it's
bad.
Prognosis, not good.
Yeah.
Not good.
So basically what we're trying to say is if you have any wound on a horse's leg,
yes,
please call as soon as you see it.
Call your veterinarian ASAP.
And let them come and do all the things.
Yes. Because
they can be life-threatening.
Yes.
Yeah. And, and if they're not maybe life-threatening, they're definitely career-threatening. Mm-hmm. So.
Well, I think it's important to remember, too, we're really fortunate here. We have a hospital. We have an operating room. We deal with these a lot. We have experience with them. Mm-hmm. If your veterinarian doesn't have the experience with them and they're like, hey, I need to send you somewhere, you need to go.
Go.
You need to go.
Please.
These are not, there's times we can wait and see. Mm-hmm. There's times we can't. And like some of these, our risk is minimal, but the problem is the consequences are high. And so some of these, like,
oh, that's good.
Yeah.
Yeah.
And so that's why I say, like, all right, yeah, our risk is minimal here, but the consequences are really high.
So if we're wrong, or if we're right, say, like, we could be in a really, really bad place
quickly.
Yeah.
Quickly. I always like to say, I think the key to medicine is go kill mosquitoes with sledgehammers. Like, you can use a little fly swatter. That's great. But I mean, I've swatted a lot of flies in my life and like got them, and they kind of buzz off. You hit I was a blacksmith. You hit a fly with a sledgehammer,
it's dead.
It's dead. It's dead. So that's just always been my theory on practicing medicine. Anytime I've got a situation where the consequences are high, let's go kill that mosquito with a sledgehammer. Let's don't take our chance with a fly swatter.
Yeah.
Let's kill this thing.
Yeah.
So, but yeah, that's the other thing I tell people is like, we're very fortunate. We have a hospital. We can do a lot of these things. If you're in a situation where you can't, and your vet's like, I want to send you, we need to find a trailer. We need to get hooked up, and we need to go.
Yeah.
It doesn't need to be like, oh, well, if it's not better in a couple of days, I'll go. Because then what you're running into is you're putting whatever veterinarian just inherited that case, you're putting them behind the 8 ball, and they're scrambling, they're hustling. And the outcome's not going to be near as good.
Correct.
Like early intervention. Like that's the key to most medicine is early intervention and doing things the right way as soon as possible.
Yeah. And if, I've had situations where, people have waited and I get out there and I'm a little frustrated because now we've got this whole smorgasbord of issues that we've got to tackle. And I'm like, I'm not trying to make you feel bad, but I'm kind of trying to make you feel bad because like we could have done better.
Right.
And we could have done better for the horse at the end of the day. And, it can be frustrating because we've got all these consequences in our minds that we're like, crap, this is not good.
Right.
So, yeah, just please call. We want to help.
Yes.
And we're going to be a heck of a lot happier if you call us early than if you call us in 3 or 4 days. Yeah.
No, it's really critical because, like I said, these wounds on the lower legs, really just a leg in general. People see these really big cuts like on the hip or on the neck, and they're like, "It's so terrible, it's so terrible." We're like, whatever. All of a sudden, you get a 2-inch cut on the back of a passenger, and we're
I'm like, "Oh no,
we need to be there now."
Yeah,
and that's why.
Yeah,
because like that cut on their rump, that cut on the neck, it's gonna be fine.
I've stitched up some massive lacerations, deep lacerations on the trunk and the shoulder and the butt and all the things, and there's a lot of meat there before they get to something really important.
Right.
So like, don't wait on those either. We need to see those and stitch them up, and but yeah, you show me a little nick on over the fetlock joint, and I'm like, oh no.
Yeah, this is bad.
This is bad.
This is bad.
Yeah.
And like I said, we're going to do a lot of testing on them, and that's really important. When you're a veterinarian, it's like, I need to do a contrast study. I need to pressurize this joint. I need to do these things. There's a reason behind it, because they understand the consequences of what to you looks like a little wound. We see the consequences.
Yeah.
So, yeah, it's really important. So don't hesitate to call. And like I said, if I could encourage people with one thing, because I hear this so much, people, I hate calling the vet, and I get it. It costs money.
It does.
But we're all really nice people.
Yeah.
And if your vet's not nice, find a new one. I mean, because really and truly, I don't know that many non-nice vets.
That's true.
I mean, we generally are just out here just trying to help some people, help some horses. I mean, that's why we do this.
Yeah.
So vets are nice.
Yeah. And we all have bad days, but for the most part,
we want to help.
Yeah.
We want to help. And I mean, I hear all this stuff about, I just dread having to call the vet. Why? Like,
if you call sooner, we can save you a lot more money and heartache.
Yes.
Than if you call later. So please call.
And we really want to help.
Yeah.
And you know what?
I love wounds. Wounds are great.
Yes.
They're really cool. Not always for the horse, but they're cool for me. So.
I would say I like the beginning stage. I love it when y'all have something that's got a septic synovial structure.
Yeah,
like, hey,
Dan can flush it for me.
Dan, this thing needs surgery. I'm like,
yes. And then he gives it back to me, and then I manage it for 2 weeks.
Fantastic.
And I'm like, wow, look at it. It's getting beautiful every day.
Fantastic. I love it. I love to go in, surgerize it.
Give it back.
Give it back. Long-term chronic management, that's not my...
Oh, I love it.
Oh, I'm so happy you do. Because I just like go I do that a lot. Even cases I take in, like, hey, I took in a septic joint last night. You want to take over?
Sure.
Because I'm not that guy.
Yeah, that's okay. We all have our strengths.
Yeah. So cool podcast today.
Yeah.
Hope everybody learned something. Hope you learned I guess it's kind of like real estate. Location is everything.
Yeah. This also goes for eyeballs though. Like if you have a wound on or near an eyeball, you need to call for that too.
Yeah.
Yeah.
Eyelid lacerations. We need to get those back together. They can have long-term consequences.
Oh yeah.
I love an eyelid laceration.
Oh, they're so satisfying.
They are.
A little plastic surgery action, get you through the day.
And then when you put it back together, it's
great.
It's so cool. Figures of 8. That's so much fun.
Yeah.
Love it.
Yeah.
So yeah, location's everything.
Yes. Location is key.
Killing mosquitoes with sledgehammers.
Mm-hmm.
Great way to do things, in my opinion.
Yeah.
So,
risk may be minimal, but the consequences are high.
Yep.
I like it.
We need a t-shirt.
Yeah, we need a lot of t-shirts, honestly.
Maybe some bumper stickers.
Yeah. All right.
So, all right. Well, Caitlin, thanks for being here this morning.
Yeah.
April, thanks for recording all this. Casey, thanks for editing. Thanks for putting the pictures up. And I'm supposed to ask y'all to like and subscribe. So
do that.
Yeah, if you like the podcast, like and subscribe.
If you don't.
Yeah, if you don't want to, just listen to it. Like I said, we do this for education. We do it for fun.
Yeah. What episode number are we on now?
I have no idea.
Almost 90.
90.
Almost.
That means episode 100's coming.
What are we gonna do?
We gotta do something fun.
Oh yeah.
Maybe we'll troll the internet again.
I think we should troll our phones.
That'd be fun. Troll the phone.
Yeah. I've got some wild pictures. And text messages. I've got some wild text messages too.
I'll never forget. My nephew looked at my phone. This was years ago. I was showing him a picture of something I did, and he started looking through some other pictures. He's like, "Uncle Dan, you got some really gross stuff on your phone. Yeah, a veterinarian's phone is
it's a magical place.
I know. Everything between how we put people in his contacts to I've got some great memory aids for contacts in there, and
if you answer the phone, prepare to be on the phone for at least 30 minutes. Go.
I don't have that one. Use it as like horse name so and so.
Yes. Oh yeah. I'm terrible at remembering people. I can remember horses all day long, but people.
So yeah, and then our pictures. It's
gosh.
Yeah. It's
Wild.
amazing. So,
Anyway.
yeah. So, like and subscribe if you want to. If you don't. Like I said, we're doing this for fun and for just educate the general public out there. And, again, veterinarians just trying to help people out. So,
Every day.
yep. So, thank y'all for listening. Thanks for all the people that make this possible. From all of us here at Countryside Equine Hospital, y'all have a great week. Take care.
Great day.